This is Selma Schimmel for the Group Room at the ESMO 2012 Congress happening now in Vienna. I'm very pleased to have us joined by Dr. Nathan Cherny, Chief of Cancer, Pain, and Palliative Medicine Service at Shaare Zedek Medical Center, Jerusalem. Hello, Dr. Cherny.
Hi, great to be here with you again.
To give viewers a perspective, what percentage of the world population really suffers from agonizing pain with no relief?
It's probably between 70 to 80%, which is globally, which is a really frightening figure.
Is the pain 1 to 10 pain scale, is that our best method?
Some people do well with a numeric rating scale. I've got some people who are confused by it. Then I'll say, look, is your pain mild, moderate, is it strong, or is it so bad that you don't want to jump out the window? You know, to use a verbal rating scale that people can relate to, because not everyone can use a 0 to 10 scale. But you need to find common language, and when you hear the language, you need to learn to believe the patient, because there's often a psychological barrier for doctors that a patient under my care is having so much pain. Oh, couldn't be. Okay. So one needs to take one's ego out of this and listen and to respond directly to what the patient is saying to you.
What about obstacles with family members?
They sometimes exist. More often than not, family members are just as concerned with patients of wanting to have people have their loved ones comfortable. But sometimes we do have family members who have, who have concerns either that their loved ones may become addicted, or that the drugs will make them sleepy or compromise their ability to talk and communicate, and that's an education process.
I know that it's very important for us to sort of distinguish that while we're very concerned about end-of-life pain control, that the concept of palliative care shouldn't be boxed into an end-of-life issue, but rather that it becomes part of the cancer continuum as a quality of life, quality of care issue.
We deal with patients at all stages, and when patients come to us, we say we want to give you the best of technical care to control your disease, but we want to help you to live as well as possible at every stage, and that means working with you on your physical well-being, on your emotional well-being, and working with your family. The issues change through the through the course of the illness, sometimes with peaks and flares along the way. But good quality palliative care needs to start early on, because these quality of life issues and the way that cancer can undermine one's life either physically or psychologically need to be, as soon as there are perturbations, they need to be addressed.
Dr. Cherny, I know that you have a talk still coming up here at ESMO, Supportive and Palliative Care, Core Elements of Quality Cancer Care.
The terms palliative care and supportive care have actually caused a lot of confusion as to what is what. There was a really interesting survey done a couple of years ago at MD Anderson Cancer Center in Texas, where the palliative care service asked the medical staff in the hospital if they would be more likely to refer patients if the service was called palliative care, and supportive care. And this relates to again these issues of psycholinguistic associations. And what they found was that if it was called supportive care rather than palliative care, that doctors felt that they would be more comfortable in referring their early stage patients to the service, and as a consequence they changed their name. There's also an international organisation, MASC, a multinational association for supportive care and cancer, which focuses its activities on studies of methodologies to reduce the side effects of treatments and to look after the well-being of patients who are survivors. A different calling from palliative care, but clearly with overlap issues. And I guess my concern has been that when these issues are conflated and confused, We have supportive care organisations that have a big focus on all of these things like antiemetics and the use of erythropoietin to raise hematocrit and things like that, without a lot of emphasis on palliative care issues. And we have palliative care organisations that sometimes claim to be involved with all aspects related to quality of care, quality of life, and yet they don't touch on the treatment-related side effects. And I think that we really need to recognise that there are two important, separate, complementary disciplines here that are both really important, and that both of them need to be emphasised independently. Both need to be developed as academic disciplines. So what we have is really two separate but related disciplines. A discipline of supportive care, which is very much focused on minimising the side effects from treatments and helping people get through treatments, and with people who are cured, looking after their rehabilitation and survivorship issues. And that is complementary to palliative care, which is looking after physical and psychological distress at all stages of disease. And they are both important disciplines, and they both need to have academic resources allocated to them, resources in meetings, resources in publications, and in the development of clinical services.
In some way, this whole issue is really medical, sociological dilemma.
20th and 21st century medicine has been about conquering diseases, and we need to broaden that purview to say that conquering disease is important, but so is care for those who can't be cured.
Thank you, Dr. Nathan Cherny, the Norman Levan Professor of Humanistic Medicine and Chief of Cancer, Pain, and Palliative Medicine Service at Shaare Zedek Medical Center in Jerusalem.
Pleasure. Thank you very much.
I thank you very much.